Well, here we go. Let's get this lecture finished up. Looking at the borderline personality disorder under cluster B, we had already checked out antisocial and went through that. So let's assess this person. Let's think about their perception and what they see. Perceives others as either good or bad. It's all good or all bad. There's no in between. And with that, they will split, meaning they will look for the good people and comment how wonderful and trustworthy they are, and then the bad people in their life are bad, and there's nobody in between. And by the way, that can switch up really quick. So if you are already a good person, just do one little infraction and you are now a bad person, just like that. And again, no in between. In terms of viewing themselves, they lack a clear self-view. And this is the personality disorder that has the biggest hole in their self-esteem. And so they don't see themselves really at all. There is no self. They would say a lack of self. And with that identity disturbance, their self-image, they get sometimes confused about sexual orientation. Where do they fit socially? What kind of work roles? They just don't know because they just can't see themselves as being this whole person. Cognition includes confusion because of these, the way they size people up or situations up, all good, all bad, and not sure which way to go because remember, there's no in between. There's no a little bit of good and a little bit of bad. It's either all bad, all good. And they have a lot of failures in life and they don't learn from them. Can't see that. And furthermore, no problem-solving abilities. In terms of affect, they will change from stable to normal to angry to normal to unstable, etc., etc. It just goes rapid changes in terms of moods. There's an intensity of the affect too, so it's very angry, very lonely, empty, they get very impatient. They fear loss and abandonment, but they have this intense, long depression that goes along with losses. They feel entitled, have special privileges. They are otherwise, though, appear to be scattered, not well organized. And they, too, just like the paranoid person, is looking for life meaning through others. And others, the paranoid person, I want to clear that up in terms of how they perceive things. And so things happen in the world and they go, just happen because of me. And I didn't really make that clear in class, and I couldn't really think of a good example. So, in terms of maybe getting a poor grade on a test. I know that's kind of a sore point for some people listening to this, but they would say, well, that's just always the case. That's my luck. That's just what happens to me all the time. And or may even think that because of a certain situation happening in the environment, that was a cause to why they didn't do so well and whatever. Okay, back to the borderline person and looking at in terms of life meaning from others. A little bit different from the paranoid, but they remember empty, vacuous self-esteem needs to be filled by somebody else, and so they're getting the way they see life from others, not from inside. And external locus of control just validates that even further. Everything is that's part of your life, that's around your life, is the locus of control. And so there's nothing that they can do themselves. It's everything else around them that makes life happen for them. Not that they had nothing to do with it in a lot of cases. Okay, so moving along to behavior disturbances, extra spending, sexual promiscuity, food and drugs, lying, stealing. Just taking all of that, that's compulsions. So along with it, you see a lot of compulsive behavior, self-mutilation, for attention seeking, or when there's when they're feeling abandoned, lots of manipulation, whining, self-criticism will evoke anger in others, and that's again to fill that esteem that's empty. But they're seldom assaultive, though they can be intimidating in your face. And lastly, in level of adaptation, the very difficult life, lots of series of beginning and endings in relationships, very unstable there. That means numerous relationships. They're challenged in school and work. They have drastic lifestyle changes because they're running from one thing to another, always trying to find happiness and to fill that self-esteem. They seldom can realize their full potential because maybe of this transition, moving from one place to the next. And they will seek health services really related to the depression, psychosis if they stay on the panic end of the mental illness scale, and or even suicide attempts, and sometimes completions, although the completions are usually unintentional because they weren't found soon enough. So they will actually go through with suicidal gestures, taking pills, and calling somebody, and if that person doesn't pick up, they may in fact overdose, and they didn't really want to. They wanted to be rescued. And overall in life, very difficult to adapt. If you really think about this, and let's bring it back to the psychoanalytical theory on self-esteem and how we have to gain that and build that and keep that going in our life through coping mechanisms, through looking at even using our ego defense mechanisms, are there to build the self-esteem. And these guys with the borderline personality have such a hard problem with it. The last cluster is dependent, obsessive compulsive, and avoidant. And so they're the more anxiety-driven clusters. And in looking at dependent, this person relies on others, needs to be taken care of. And again, this is the person that really needs, to have people around them do things for them. And they're not helpless, they're just super dependent on everybody else to fulfill their needs. Obsessive compulsive would be along the lines of the hoarder, and so they can fall into that. And then again, it's very anxiety provoking. And avoidant, socially inept, avoids gatherings, just avoids a lot of things in life, making it very hard for this personality to get out there and work and do things. Will do it, but will avoid all kinds of things in terms of maybe socializing after work and what have you, really keep to themselves type of person. Next slide. So looking at, I think I just have one of these, and that's obsessive compulsive. Perception and attention to new information or different viewpoints. So if you'll look and see kind of like rules in the next column, and rigid thinking, and that's because they can't see how others are think and looking at other viewpoints. It's all about the way they think, and that's all there is. Sharp focus, select detail, meaning that they really will focus in on things and pay attention to details. And when you look at the hoarders, boy, they really know where everything is at. Even though things are stacked up, they know exactly where things are. And they're very detail-oriented in terms of where they put things and how things are done. Next column over talks about cognition, so rigid thinking. Rules. They have intellectual rigidity, goes with the previous column, not able to accept other viewpoints, inattention to new information. When they're on topic, they stay on topic. They're unable to change the topic. Almost will perseverate on one thing over and over and over again, and you have to really it's a really challenge to get them off a topic. Rules, standards, codes, moralities, or legalist, dogmatic, and again, following rules, don't break the rules. Next column over, this person's affect is usually anxious or ambivalent. They have forbidden emotions, like you can't react happily, and this I've given you some examples in terms of a patient I've taken care of, and this really strikes me because he was unable to have any emotions or impulses in terms of spontaneous laughter over things. He just didn't, and I saw him and did these dressing changes on his wounds for 2 years before I cracked a joke and he was able to actually laugh at it. And I even pointed it out to him. I said, "Oh my gosh, you're laughing." And he says he doesn't do that with many people, but he was feeling okay to do that around me. So that was really impressive to me. I felt very good about that he trusted me that much to laugh at a joke. But let's just go down the list here. The last bullet point, resents others. So again, very hard with all these patients to gain any type of trust. Very, very difficult. Next column over talks about behavior disturbance. Very stubborn, will conform, very obedient. And so this is another thing, is that I actually worked with this patient I had in terms of him abiding by the rules of his dressing changes and made things and telling him that this is the way we had to do it and this was a procedure. But then if the dressing change procedure changes up, he questions that. Why are you doing that differently? Okay, so would conform and be obedient, but boy, you change it up and he would have some issues with it. Excessive, neat and clean, and even in their hoarding, if you're looking at a hoarder, they're going to have, they're going to know where everything is. It may not look really clean though, they tend to overlook those things. Controlling, insist on the right way, has in terms of behavior is kind of cold towards others. Self-centered, demanding, and pack rat is another name for hoarder. Okay, and again, they're not going to have all of these bullet points in every column, but they're going to have some of these, which adds up to this person usually, having a personality disorder. But again, it has to be really fully tested. Okay, last column is about adaptation. They're adaptive in some settings, in some work settings, in fact. They're an ideal worker. They're not drawn into therapy because therapy would only stress and overwhelm them. And coping presents with symptoms of, or will overwhelm their coping, They present with symptoms of anxiety. They have sexual problems, unable to get close and form relationships. And because of this constant, they're on all the time in terms of rules and things that have to be done in this rigid way of thinking, they get exhausted over that. And it can lead to depression because nothing ever gets quite right. Okay, next slide. Okay, looking at characteristics of all personality disorders. So we looked at some, and just to think of the major components for those that we're talking about there. And this also leads up into other lectures we're going to have. Okay, so something that happens with all is they will typically split all good versus all bad, some more so than others. We see that in our borderline particularly, but most of them will split. And again, comes back to that trust, such a lack of trust. Projection, fault finding and blame, passive aggressive, being indirect expression of anger, meaning that if you are the nurse and you don't show up on time, the next time you come and visit, let's say this is a home care situation, they may be out shopping, and because you didn't show up on time the last time, so they will do something to let you know that there is something wrong, but not getting in your face and telling you about that. Okay, acting out, direct expression of feelings through behavior, so unable to express feelings, but will behave in ways to show you how they're feeling. Narcissism, self-love better than others, and again, this makes it a problem for getting therapy, but they are dependent. They have unreasonable expectations, and that goes to the lack of self-esteem and requiring everybody else to fill that. And because nobody can really do that for them, no-win relationships go absolutely nowhere. Okay, so remember, in assessment, you have to look at the physical, emotional, cognitive, social, spiritual side of people when you're really looking at them through looking for mental health issues. Some nursing diagnosis: high risk for violence, self and at others, and so looking especially at people that are more susceptible to self-harm, like the borderline patient, or towards others, that would be your antisocial person. Self-mutilation, we're going to see that again more so with your borderline person. Definitely defensive coping, self-esteem disturbance, impaired social interaction, and knowledge deficit, because their insight is so low in terms of understanding what is going on in their life, and unable to see it in themselves, but rather blaming everybody else. Next slide. So for your planning and intervention, the first thing you need to plan for is that you're going to hold it together. Nurse is going to keep control here, because remember, these personality disorders are so ingrained and they are so strong that it's very difficult sometimes on the person trying to care for them. So be aware of your emotional and potential to become frustrated. It's going to happen. The second thing is trust. Remember that. Develop the trust, respect, congruence, show that you're congruent in your verbal and nonverbal. Just be reliable. This does not happen overnight to gain the trust. It happens over repeated. Remember, they're testing you, making sure that you're going to be trustworthy. And counter projection, point out when they are blaming others that what is your responsibility, and you want to counter project that and point out what they're saying and doing in terms of that. Time out from having a one-to-one if needed, because they will get under your skin. They will be very negative, and again, a lot of this blaming, it's very difficult to deal with. Confrontation on behaviors that are not appropriate need to happen as soon as possible. Lots of limit setting, consistent, like a broken record, repeated over and over and over again. And there must be continuity with our meds ever used. Nothing out there for personality disorders itself, just the meds for the Axis 1, and of course Axis 3 if they have a medical problem. But in dealing with the Axis 1, for instance, mood disorder, it might be some antidepressants, and coupled if they have some bipolar issues, lithium and anticonvulsants. For anxiety issues that go along with this, anxiolytics. Anticonvulsants can also be used here. And remember, our friend Klonopin can help with that. Violent behavior, of course, we're going to use antipsychotics and maybe some beta blocking agents. And in terms of people reliving trauma, we can start looking at some of the antihypertensives that go ahead and lower your heart rate. All right. Evaluation. So just remember, we all have personalities, and these have been with us for a very long time. Undoing non-productive personality traits takes a great deal of understanding, patience, and persistence on both the patient's and the nurse's part. So good luck. And lastly, this is just a concept map of the, in terms of personality disorders, and looking at the different clusters, A, B, and C, in terms of the flowers, and some key things that you would see in terms of nursing diagnosis on the leaves, and then going down into the roots and what have you. Where do these come from? How do these manifest? Okay, I think that's it.